Today it is my great pleasure to welcome an external speaker, Dr. Sarah Blissett. She is an assistant professor of medicine and cardiology and the program director at Western. Her background is that she completed medical school and internal medicine at the University of Toronto and then went on to cardiology at Western University. She then went on to do advanced fellowships in cardiac imaging at McGill, where she did echocardiography and cardiac MRI, and then further trained in adult congenital heart disease at UCSF in San Francisco. Concurrent to these fellowships, she also obtained a Master's of Health Professions Education at Maastricht University, and that's ignited her interest in education, which I think she's going to speak about today. Dr. Blissett's clinical work focuses on cardiac imaging, adult congenital heart disease, and cardio-obstetrics. As a center researcher at the Center for Education Research and Innovation, her academic interests are focused on improving education in cardiology, particularly in optimizing learning in the workplace and learning environments. So Sarah, thanks for coming, and we welcome you.
Thank you. So thank you very much for that kind introduction. It's a pleasure to be here today and speak to you about cardiology education. In moving forward, I wanted to go through my disclosures here, and through the next 40 minutes, we'll discuss some of the opportunities to advance cardiology education and highlight the challenges and realities we face in doing so. As an educational researcher, I oftentimes gravitate to educational theory, and I recognize not everyone does. So I'll try to keep this very practically focused and integrate the theory where it might be helpful. I'm also a non-invasive cardiologist, so much of the research I've done is in a non-invasive context. I'll try to highlight how it's applicable to the more invasive inclined subspecialties in our field as well. In the past 5 years, competency by design has definitely shone a spotlight on cardiology education. Some of this has represented both opportunities and obstacles for us, but today I'll focus on some additional opportunities and obstacles rather than the competency by design implementation. In doing so, I think it's first important to acknowledge some of the realities that we're facing. Across training programs, universities, countries, and continents, there's more resources required to deliver medical education in 2025 than before. Using CBD as an example, there's more IT platforms, human resources, and time required. And consequently, this often means that we are doing more with less. And this parallels what we face in our clinical context as well. Many are facing constraints in their clinical work, and it's important that as we try to innovate this field, we take the available resources into account. We also see that trainees are required to have an expanding knowledge and skill set on graduation. Recent data from Canada, led by Dr. Nair, showed that 95% of cardiology graduates are engaging in at least 1 year of fellowship training. So consequently, we're seeing longer training durations and different personal and professional goals incorporated within that longer training duration. This has also led to an emphasis on learning efficiency. How can we most efficiently teach people the skills that they need? Can we reevaluate cardiology training? Are there aspects that can be deprioritized? Can we relook at the training duration? We've also seen an accelerated cadence of change. In the past 5 years, there's been the implementation of CBD, an unanticipated global pandemic, transition to a spring Royal College exam, and the ECHO group would love to train or change how we train echocardiographers. This means that training programs are continually adapting, and it feels that as soon as one adaptation might be finished, then it's like whack-a-mole. Another one comes up and the training programs need to change course yet again. Furthermore, we've seen evolving assessment frameworks, and this has meant that trainees and faculty are also continuously adapting. So these are the realities of the medical education framework that we're currently working in. Furthermore, when we look at scholarly work in cardiology education, this study is from 2016, so getting a little bit dated, but I imagine it would have similar findings today. In 2016, 19,000 articles were published in cardiology, general medicine, or medical education journals. and of those, less than 1% related to medical education and cardiology, and less than 1% of authors in medical education journals were cardiologists. And while I was thrilled as an internal medicine to be included in this count, it really highlighted to me the opportunities that we have to generate evidence around the educational strategies we're using in cardiology. And to compound this, recent studies have identified how our cardiology graduates have opportunities to improve in their competencies. I've shown here some examples on ECG interpretation as well as echo interpretation. So with this all in mind, there are certainly many opportunities, and this is a ripe field for innovation. So I'll go through now 5 opportunities that we have to change the trajectory and ensure that our cardiology graduates finish their program with the most knowledge and skills. The first is to be deliberate about enhancing workplace-based learning. I think we all recognize that most of the learning in cardiology training and subspecialty training programs occurs on the wards, in the CCU, in the clinics, and in our diagnostic labs, and that this is very different from learning in a classroom. So to think a little bit more about how we could do this, I'll just take a step back for a brief minute to describe some of the educational theory that's relevant. The first is about the dual store model, and it helps us understand how we learn new information. And this was initially proposed in the 1960s and received a Nobel Prize designation. It highlights that there are many stimuli all around us every day. There are sounds, images, tactile stimuli like the feeling of puncturing pericardium, olfactory stimuli like the smells of diabetic foot infection. And if we choose to pay attention to them, then they can enter our working memory. And our working memory is really our short-term memory. And you can see here it's a much smaller box, and that's intentional. It's quite limited in both space and time. Experts initially stated that it was limited to 7 plus or minus 2 facts, and that's why our phone numbers, when we used to dial them, were 7 digits. It's also limited in time. So many of us can probably appreciate going to your office or your kitchen and realizing, I don't know why I came into this room. And that really highlights the limitations in time. So information enters our short-term memory, and then the goal is to get it into our long-term memory so that it can be stored. To do that, we really need to do something with that information, encoding it or processing it so that it can make it into our long-term memory, which, as you see here, is a much bigger box. It's thought to be infinite in its storage. And then when we want to use that piece of information, again, we need to be able to retrieve it. So we need to store it in a way that it's stored with other relevant information so that when we go to retrieve it, we can find it. This dual store model highlights 2 practical aspects. Firstly, knowledge is not transferred, it's constructed. So when we're providing instructional teaching, we have to provide elements in that teaching so that the learner can construct the knowledge related to something that they know before or compare and contrast. Unfortunately, we don't yet have a USB transfer from trainee to, or from teacher to trainee. The second aspect that it highlights is that our working memory is truly the bottleneck for learning. And if we overwhelm working memory by presenting too much information or in an inefficient manner, then we won't be able to store that new information in our long-term memory. And that's where cognitive load theory comes in to maximize working memory use. And again, I apologize, there's a little bit of theory here, but I promise we'll get through it quite quickly and move on to the practical aspects. So cognitive load theory is an educational theory designed for classroom settings to maximize working memory. There are 3 subtypes of cognitive load, which include intrinsic, extraneous, and germane. And I'll find some examples of these next. So intrinsic load relates to the cognitive demands required to complete a task. So really, how many steps are there to completing the task? How is the information integrated with other facts? For example, if you had a novice cardiology resident and ask them to perform a diagnostic angiogram, that might be quite a challenging task for a C1, and many of us might be able to remember that and learning that skill. But for an advanced angiographer or someone who's cathing every day and this is their career, it's probably a very simple task. So it really not only depends on the number of steps in the task, but also the knowledge level of the learner. And even the most experienced expert might still run into challenges, like if we took that normal angiogram and put it in a patient with dextrocardia, that still might be a challenge for the expert. So the bottom line here is that intrinsic load depends on the complexity of the task and the skill level. And ideally, we want to match the complexity of the task with the knowledge level of the learner. Extraneous load is any cognitive load that's not essential to task completion. So that could be inefficient instructional methods. It could include distractions like being called or paged during a teaching session, which I didn't plant that timing. It was beautiful. It's really anything that takes away from learning how to do the task. And I think you can kind of think about this in the workplace. There's many of those challenges that can come up. Germane load is any processing to retain new information. And oftentimes in our workplace settings, that relates to an interaction with a supervisor or senior near peer to discuss that new information or to compare and contrast. Why is the management of the patient in a bed in the CCU as cardiogenic shock due to severe aortic stenosis different than the management of a patient with de novo heart failure? Can we compare and contrast those and help you build more robust knowledge networks around management of cardiogenic shock? So the germane load is really that processing that helps us take information from the working memory into our long-term memory. So if we conceptualized our working memory as this finite box, then we would want it so that the intrinsic load and extraneous load of whatever task the trainee is engaged in don't consume working memory so that there is some available for that germane load. Practically, this means that we're trying to help trainees manage their intrinsic load by setting them up with tasks that are of appropriate complexity, minimizing extraneous load, and promoting germane load with something that helps them process the information. Taking this from the theory to practice, as a keen internal medicine resident, I conducted this randomized trial looking at how to improve teaching of murmurs, which I think is a challenge oftentimes for medical students to learn. And we applied cognitive load theory to study two different instructional formats. The first was the traditional diagnosis-specific lists around all the features of every murmur. And the second was this diagnostic algorithm, which really clinically oriented the learner. So firstly is a systolic or diastolic murmur, where is it heard loud list, provided them a differential, and then readily available distinguishing features. In doing so, we help them manage their intrinsic load. We minimized the extraneous load by only focusing on what they needed to know. And we promoted germane processing by having them compare and contrast and provide a differential diagnosis. And it all kind of worked out with the theory and practice because those who were taught with this format passed their practical test of murmur identification on Harvey, whereas those who were taught with the traditional framework didn't pass. And that was exciting for me in applying cognitive load theory and thinking about how we could improve instructional design in the classroom. And we then moved on to look at this in ECG interpretation, as well as multimodality imaging, and showed that these findings in controlled research settings also translated to classroom sessions. Coming back to cardiology, how do we do this in our day-to-day lives? Well, we teach a lot of procedural tasks. Here I've shown a diagnostic angiography again, and emphasizing that we don't necessarily teach the entire skill at once. We break it down into part task practice. Oftentimes the trainees will focus on vascular access and then manipulating catheters, then manipulating the tables, all while learning how to interpret the images. I recognize some of the goals around diagnostic angiography have changed with CBD, but we also use this in our echo labs. We don't necessarily expect all the trainees to learn how to acquire all the images on the first day. We focus on the parasternal long axis and the short axis, apicals and subcostals. So we are doing this in our day-to-day work already. We also oftentimes try to scaffold complexity, have trainees engage in easier tasks, master those, and then move on to more difficult tasks. Another point about procedural tasks comes from my dear friend and colleague, Justin Sewell, who's a gastroenterologist. So a lot of his work comes out of colonoscopy, but I think it's relevant to us. And he looked at all of the teaching moments when GI fellows were learning how to do a colonoscopy. And he found that most of the teaching was around motor instruction, which makes sense because they're not only learning a procedural task, but they're also learning to interpret it as they go, just like we do with a lot of our imaging modalities. And what he found was that in the blue and the orange, most of the teaching moments occurred when the trainee was doing the procedure. Very few occurred before or after the procedure in yellow. And his work really highlighted the role of optimizing working memory by taking advantage of the time both before and after the procedure, making sure that the trainee is aware of the steps or anticipated challenges and how they might navigate them. And this work has really informed how I approach teaching transesophageal echocardiography. As I alluded to, we spend a lot of time teaching in our workplace learning environments, CCUs, inpatient wards, clinics, and diagnostic labs. And it's more than just the trainee that we have to think about in those settings. We also have to think about the patients and their needs and balance the educational needs with the patient care needs, as well as the social aspects of our workplace learning environment with all the interprofessional staff, as well as the physical and virtual spaces, which might not be as ideal as they are in our medical schools, and think about how this all fits within the organization that has its accreditation rules and the organizational practices and policies. And in thinking about this as a fellow, I was really curious that some aspects of the workplace might enhance learning, whereas other aspects may impede learning. And how could we enhance those that are helping learning and reduce those that are minimizing learning? And that led me to do a single center qualitative study situated in an echo context at UCSF, which this is the reading room there, if anyone has been to that before. And we felt that echo was a great place to start in looking at this because we're aware that there are some gaps in diagnostic accuracy of our graduating cardiology residents as it pertains to diagnostic interpretation of echo, and echo is predominantly learned in the workplace. And so we embarked on this qualitative study to find out what enhances and impeded learning in this environment. And we conceptualized those factors that impeded learning as really extraneous load. And one of the major sources here was a lack of an orientation. So certainly all the residents knew where to come, where to go at the right time, but they didn't necessarily know how to use the interpretation software. So not only were they trying to learn how to read an echo, they were also trying to learn how to use the reporting software, how to view the images, make measurements, and even complete the report. And there might be some parallels to other domains in cardiology that are relevant there. They found interruptions to be quite frequent. A lot of them were phone calls for orders or clarification, and time pressures were pervasive. On balance, though, they did also identify many factors that enhanced their learning. From an intrinsic load perspective, they focused on guidance around task selection, and some of them came up with their own ways to scaffold from easy, intermediate, and hard. They used the indication for the echo, so a person with palpitations, new murmur, or pre-chemo that was under the age of 40 was more likely to be normal for them. So they started with those, whereas the VADS, Fontan were more complex studies. So they could kind of navigate that a little bit, but they did desire more guidance around task selection. From a germane perspective, they found that having teaching attendings and near peers in the reading room helped them. And I think there are some great examples that we discussed last night over dinner about how that might help. They also recognized that it wasn't always feasible to review every echo with an attending or echo fellow. And they found that checking their preliminary report and comparing that with the final report that the echocardiographer had signed off on was really helpful. So some, but not all, kept a log of all of their preliminary reports, and then at the end of the day or the next morning would compare them. Now, this was a single center study, so we then conducted a larger multi-center study of 60 cardiology programs across the United States. And we found that these factors that enhance learning were sometimes, but not always present, kind of in the 50 to 60% range. Importantly, they had guidance on which transthoracic echoes to select about 37% of the time. And if the task is the teacher in the workplace, we really need to make sure that the trainees are interpreting tasks or engaging in tasks of appropriate complexity for their learning. They also reviewed echo interpretations with their attendings only about 36% of the time, which I think is the reality of the workplace learning environment, but also highlights how we need to help trainees identify strategies that are independent of the attendings. And those factors that impeded learning were nearly always present. Very few reported that they were oriented to the reporting system to view images, complete reports, or make measurements. And they found that unfamiliar with the software, interruptions, and time pressures made it more difficult to learn echo. So when we put these all together, there are some practical strategies that we can take away to improve workplace learning. From an intrinsic load perspective, we need to really think about matching the task complexity to the learner's skill and knowledge. And there might be different ways this can approach. In our inpatient units, it might look different than in our diagnostic labs. We need to minimize extraneous load and specifically providing an orientation, not just to the rotation, but also to all the tools that they'll use, whether that's the EMR or diagnostic software. Ideally, we would want to minimize interruptions. Radiology has taken on some innovative approaches by assigning one resident specifically to answer the phone and deal with the interruptions in some settings. And then the others all focus on interpretation, and they all, of course, take a turn on answering the phone. And they can develop non-medical expert competencies through that. So that's something that has been reported in the radiology literature. But I would argue that we shouldn't take away all interruptions, because there's not a day that goes by that an expert isn't interrupted or distracted. It's a part of our job. So we need to have skills that allow us to be distracted or interrupted, that don't completely derail our decision-making or our teaching. And from a germane perspective, we really need to incorporate something in whatever it is we're doing that allows them to process the knowledge, whether that's in a teaching session or at the bedside, and do whatever we can to promote feedback. In our echo context, we have a busy echo lab at Western, and one of the strategies we've used is designating an hour of the day that's specifically for feedback around echo interpretations and teaching. So moving on to the second opportunity, which ties in very closely to the first, which is to provide guidance on task selection, because really if the task is the teacher, we need to get that right. This led to a national study. Some recent cardiology graduates from Calgary program participated. We looked at how trainees pick which echo they're going to interpret. And this again was a qualitative study. And to provide a bit of educational theory here, we defined the ideal task as one that fit within their zone of proximal development. And this is a way of conceptualizing complexity in a different way. So you can see that there's 3 zones. The first zone in the middle is they can do it independently. And so if I take my ability to park a car as an example, I can certainly park a car, especially if it's a drive-through spot, very independently. But then the second ring, what can I do if I'm guided and have supports? Well, I can probably back in my car with the assistance of a backup camera or maybe someone in the passenger seat. And that's really kind of where I'll learn the most about parking. But there are things that in the third circle that I can't do even with guidance, and that would be parallel parking. It's never going to happen. But you know, maybe over time my parking skills will improve and eventually maybe I'll get there and that will be in my zone of proximal development. I'm not confident about that, but always keep an open mind. So if we were to think about this from an echo perspective, we really want the trainees to be engaging in echo that they can do and complete with maybe the support of resources or a near peer or faculty supervisor. And in this study, the trainees definitely recognized the zone of proximal development. They could find this sweet spot for learning. A C2 highlighted that the times I felt like I've really learned something and leveled up as an imager are times when I've picked something just at or above my level. When I've picked something and I really sunk my teeth in it, I spent time and that was a difficult case that I ended up learning more. An echo fellow reflected perhaps more concisely, whenever you read a difficult study, you learn more. So trainees can find this sweet spot. So it would be, it's intriguing. Are they always choosing echoes in that sweet spot? They certainly know what it looks like. And we found that, yes, sometimes they did have a goal of learning content. And if they wanted to learn content and push themselves in that zone of proximal development, they would choose a task that was of higher complexity, and they would make sure that they had some support to complete it. So whether that was an ASC guideline, the CSE Echo Math Calculator, or a near peer or attending. But they didn't always choose echoes to learn content. Sometimes they chose echoes because they needed to fulfill assessment criteria. Most of these were done before CBD, so they were really looking for perhaps less complexity of the studies, focused on those numerical benchmarks, trying to interpret and achieve that number. When EPAs came through, those trainees similarly were looking to ensure that they had entrusted EPAs that they sent forward. So there's a bit of tension there. And this third goal was most applicable to the ECHO fellows, who were very keen to contribute to clinical demands. They wanted to help the volume of the lab, and they used informal rules of the workplace to decide which echo to pick. So they oftentimes prioritized inpatient studies or outpatients that had attached clinic visits that day, or anytime they were called about a study, they would stop what they were doing, interpret it. So we did see various goals, and that led to differences in complexity. The most interesting part of this study from my perspective was that they chose tasks of variable complexity to manage their cognitive load. So much like high intensity interval training, if they engaged in a higher complexity echo, then oftentimes the next echo they would choose would be an easy one. They would give themselves a cognitive rest. And they would go through this cycle. And this was so interesting for me because it really challenges the principles of cognitive load theory that say that, they should always be operating in that zone of proximal development, matching that intrinsic load. But that's just not feasible over the course of the day. And really led us to some practical strategies. The first, I think, is the most important, is that we really need to encourage a variety of complexity in the completed tasks. Not all tasks need to be the most complex study for that learner level. And to make sure this is happening, we need to regularly review the complexity of these tasks. And importantly, trainees are going to need some guidance on which tasks are easy, intermediate, or hard. And we also need to make sure that trainees are aware of the benefits of a cognitive rest, that can help them learn more as they go through an entire day in the workplace learning environment. The challenge with all this is that through their studies, we've realized trainees struggle to identify task complexity. In the qualitative work we did, we saw many quotes like this one: "I just don't know if I see this pathology. Is it appropriate for my level?" And in the American context, trainees had guidance, or they reported they did, only on 37% of the echoes that they read. So certainly an opportunity for us to think about how we might be able to support them in identifying task complexity. This led to a multi-center study in Canada that one of our cardiology residents, Thomas Racy, has been leading, looking at how we can use either features of the echo, so the number of images, whether contrast was used, how long it took them to acquire the images, or whether teaching sonographers, like those pictured here, might be able to provide a complexity rating. And really look forward to sharing those results once they're out, because I think there'll be some practical suggestions for us to take away, particularly around the number of images in the echo, and the value of teaching sonographers, particularly for our C1s, to help them choose those easy or normal studies as they just get integrated into our workplace learning environment. Switching gears now, I want to talk a little bit about simulations. We have a lot of opportunity for simulation in cardiology, including Harvey for murmur auscultation, many task trainers, including pericardiocentesis, angiography, transthoracic and TEE, as well as high fidelity resuscitative simulation rooms with high fidelity mannequins. And these definitely play a role in our teaching of trainees, particularly from a mastery perspective, and allowing them opportunities for deliberate practice outside of a patient care scenario where they can hone their skills in a low stakes environment and receive frequent feedback. But I think we can push simulation a bit further. And as a cardiology resident, I worked with another cardiology resident, Dr. Sachdina, to look at this in our Code Blue simulations. And instead of focusing just on ACLS scenarios, we incorporated many more pre-code scenarios, seizures, hypotension, altered level of consciousness that represent a lot of the pre-code calls that our cardiology house staff were engaging with on the wards. And the residents loved this. They felt that it was authentic. The fact that they didn't necessarily walk into the room with the chart at the foot of the bed, someone had to run and get the chart, and incorporating those aspects of authenticity enhanced their ability to deal with these high stakes and oftentimes high stress situations on the ward. And as the field of simulation has gone on, there's now a term for this, which is epistemic fidelity, which is incorporating the idiosyncratic ways that ill-defined problems manifest and are managed by different clinicians in authentic clinical practice. And here I've shown an example of some innovative multidisciplinary cardioobstetrics simulations that we run twice a year at Western in collaboration with my colleagues from obstetrics, Dr. Taylor, and MFM, Dr. Banner, where cardiology and OB residents co-manage a simulated pregnant patient with heart disease. We've incorporated uncertainty and communication challenges deliberately into these simulation scenarios, because we recognize that these are the authentic ways these patients present. We ask the patient to ask questions like, do I need a C-section right now? And that's often a first question that people are asking, or is my baby okay? And they're really unanswerable questions. And in doing so, this has also allowed us to use simulation as a research tool to explore these complex, socially situated research questions that'd be really hard to get at if we put people in a room and ask them to describe the last time they felt uncertain. So we use this simulation to prime them to feel uncertain in this research question, and then through debriefing and interviews, ask them more about their experiences with uncertainty. And one of the interesting findings from this work was that in the same cardioobstetric scenario, residents were more than willing to express uncertainty to their peers. They would tell them, I don't know, I need to ask my staff, but they would not say those words to their supervisors. And this may really resonate with what we experience every day, but it's very important. These are patients that we know have high rates of cardiac events and maternal morbidity, mortality on the rise, and we need to create environments where residents are willing to tell their supervisors when they don't know. I'd be remiss if I didn't acknowledge that sometimes coordinating all of these innovative simulation tools feels a bit like pushing a boulder up of a hill. It certainly requires time, resources, logistics, and expertise that are not always infinitely available. So we need to use simulation wisely and push it to its limits where we can, and think about where other instructional modalities may suffice. The fourth opportunity we have is to design curricula to address gaps in patient care. And I come from a background of cardiobstetrics and congenital, so I'll focus on those two. In cardiobstetrics, Canadian data has shown us that provider education impacts patient outcomes. Up to 50% of serious cardiac events would be preventable with increased provider knowledge. And that's led to calls from cardiologists as well as obstetrical societies to improve provider education. The US has assessed the educational needs of cardiologists and cardiology residents, and you can see, and most of these are in pink, there's broad, high priority educational needs around cardio-obstetrics for cardiology residents. We similarly were interested in what those educational needs look like from both the perspectives of cardiology trainees, but also the obstetrical trainees, because multidisciplinary care is so emphasized, as is multidisciplinary education. And two medical students worked with me on these projects. One was a survey of current Canadian and obstetrical residents. We had about 150 participants. And the other was data that we collected from those simulations that I mentioned to you, particularly focusing on management of unstable patients. And what we found was that current clinical exposures are insufficient and multidisciplinary exposures were infrequent. So this highlights the opportunity we have to close the gap with education. We identified broad, high priority educational needs, many of which were shared between both cardiology and obstetrical trainees, which is interesting for us as we think about how we might design a curriculum. These shared needs encompassed in assessing cardiovascular risk, so who was low risk, who was high risk, safety of medications and investigations, which is very important clinically, because sometimes those are issues that lead to serious cardiac events if a medication is stopped when it should have been continued. Pre-existing congenital and acquired heart disease, physical exam skills. So in our simulations, we found that very few actually even performed a cardiac exam in this unstable pregnant patient. And that might have been a bit of the kind of mystery of simulation. Sometimes things happen a little bit differently, as well as peripartum management of cardiovascular events, including arrhythmias, heart failure, acute coronary syndromes, and cardiac arrest, and importantly, multidisciplinary skills. They highlighted to us through this work that there are many preferred instructional formats which expand from more clinical exposures, simulations, both virtual and in person, online modules, and a nationwide educational day. They also recognized they desired more interdisciplinary skills, and they had no clear preference on how the other specialty was involved. It was very important for me as an educator because oftentimes interdisciplinary education, many of us have experienced this, different specialties or allied health professionals come to one room together at the same time and discuss a case and share their differing perspectives and how they can work collaboratively. That's quite challenging just for these 2 simulation sessions a year, and would be quite a challenge to scale across the country. So it really opened the door for us to think about how we could do this asynchronously and innovatively to incorporate perspectives of both specialties. So this led us to produce virtual asynchronous educational modules around cardio-obstetrics education. And we wanted to make sure that this was practically oriented. Our trainees are very busy. We know they have expanding knowledge, skills, and requirements. So we designed this to fit within a 2-hour period, which could be incorporated into many academic half days. And we used the needs to help us guide the content. We first had a session on primer on cardio-obstetrics, which covered the hemodynamic and hormonal changes of pregnancy, as well as how to assess risk of cardiovascular events and how to work within the cardio-obstetrics teams and what the roles were. And then we had 3 subsequent modules that were situated in a case of spontaneous coronary artery dissection, preconception counseling, a patient with repaired tetralogy and assisted reproductive technologies, and then delivery planning in a patient with heart failure and systolic dysfunction. And throughout these modules, we blueprinted those educational needs, including assessing cardiovascular risk, medication safety, safety of investigations, and management, both antepartum and peripartum. Our initial data from 2 sites highlights that these modules do improve clinical knowledge scores, and similarly, those who took the test before didn't quite have a passing grade, and after they completed these 4 modules, they did pass, and they also enhanced interdisciplinary skills. And our goal going forward would be to make this available to all cardiology trainees across Canada and to adapt the modules for a more obstetrical audience. I'll now briefly talk a bit about care gaps in adult congenital heart disease as another opportunity. We know in Canada there are more adults than children with congenital heart disease, and these patients have lower mortality when they're cared for by a congenital specialist, especially if they have a moderate or complex lesion. Canadian data highlights that we only have capacity to see about 24% of these patients, and this has led to many recommendations and a multi-pronged strategy to address this, one of which focuses on education of general cardiology residents and non-congenital cardiologists. And from an education perspective, I've worked with CashNet and one of our ECHO fellows, who's a trained congenital physician, Maria Garagiola, to design a tailored ACHD curriculum. I totally recognize that all of the content that I have learned about congenital heart disease is not necessarily relevant or what non-congenital cardiologist needs to know. And there may be similar parallels to what I need to know about complex VTE ablations or complex PCI. And so we use that principle of really understanding what do these people need to know and incorporated perspectives of both congenital and non-congenital cardiologists in Canada. I know some of you have participated, and I really thank you for doing this because it was very helpful for us. We found that ACHD patients encompass about 5% of patient encounters by non-congenital physicians. So 5% is not 95%, but it's also not less than 1%. They're seeing these patients as a sizable proportion of their clinical practice. And about a third practice at a site without congenital support, and 25% are more than 100 kilometers from an ACHD center. They also assess more inpatients with congenital heart disease. We then focused on, from the non-congenital perspectives, what are their self-identified educational needs and what's their current scope of practice? What type of patients are they seeing and in what context, and what do they do with those patients? Do they prescribe medications, talk to them about endocarditis prophylaxis, pregnancy, or atherosclerotic risk? And then we also asked congenital physicians what the recommended scope of practice should look like. What we found was that our curriculum should focus on comprehensive content on simple and frequently encountered moderate complexity lesions like Epstein, tetralogy, and coarct that are frequently assessed, and include those aspects about endocarditis prophylaxis, atherosclerotic risk. Should also have content on management of common inpatient issues like heart failure and arrhythmias, and a primer on congenital heart disease that's high complexity, so that when these patients come to the hospital, there's some working knowledge about what are our priorities in the cyanotic patient, how do we approach patients with secondary erythrocytosis as examples, and also a primer on management during pregnancy, which thankfully we had addressed in some of our previous work. And so look forward to building this national curriculum with input from congenital specialists, really tailoring it to the non-congenital cardiologist. And I want to mention that when we evaluate these educational innovations, framework for doing so, these different Kirkpatrick levels, the first focusing on satisfaction of the learners, which is the lowest level of evidence, then the second focusing on learning, knowledge, or skills acquired, the third focusing on evaluation of behavior, so transfer of learning to the workplace, and the fourth would be evaluation of results. How does this improve patient outcomes? And while I think a lot of educators strive for that peak of the pyramid, we've come to realize that it's pretty unattainable in our educational studies. Education isn't a single intervention. There are many intersecting features and actions that are contextually dependent. So from an undergrad or postgrad level, it's difficult to show patient outcome data. Maybe at a CPD level, we can look into that. But so when we're designing these curricula, I think most of it's going to be focused on evaluation of learning. And lastly, I wanted to briefly mention our fifth opportunity to leverage resources and expertise and really highlight the importance of national collaborations to advance cardiology education and research. I've alluded to the fact of doing national multi-center studies, which has really allowed us to generate some evidence and highlight practical strategies that we can use, but we also need to continue that on a broader scale. Dr. Graham Wong and Michael Froschel have led the implementation of the boot camp for C1s, and all cardiology training programs have enthusiastically adopted this. This has been phenomenal collaboration to ensure that the cardiology trainees have what they need to have in their transition to discipline. And at the very beginning, incorporating non-medical skills like research, QI, consent processes into this means that not every school is providing this in duplication across the country. In the first week of July, we've collaborated together to reduce that redundancy. We also have the Canadian National Echo Project, looking at how we can close that gap of diagnostic accuracy, and there are many people working on that. And lastly, we've created the National Written Exam, led by Dr. Sibbald, to provide trainees an opportunity to practice short answer questions before our Royal College exam, which is short answer based. And that really complements the ACC and training exam. So in closing, I think there's opportunities to engage more cardiologists in education and scholarship and really help us pave the way forward with more data. And in doing so, we have an opportunity to build networks of cardiologist educators. So really thank you for your attention, and I would be happy to welcome any questions or comments.
Get it. There we go, thanks. Okay, first to the room. Are there any questions in the room? I have a question. I'll start off with. So, you didn't really talk about different kinds of learners, adult learners versus young learners. People talk about visual learners versus textual learners. Any thoughts about kind of different kinds of resident learners? Do they exist?
Yeah, so that's a great question about learning styles. And I think there's a lot of initial interest about learning styles, and learners definitely have preferences and what they can engage in most. But all of the research on learning styles doesn't connect to outcomes. So although people may identify, or we can classify them as different types, it doesn't, if you teach them one way or another, they have the same knowledge at the end of it. So that's really made us move away from that idea of tailoring to someone's learner style.
Mike's in the room here. Questions? Catherine's gone, you know that. And I'd invite people to tap into the chat if there's any questions out online.
I thought that was a lovely presentation. Thank you very much. So much information. I think one of the things that comes to mind is just even when you were putting up the congenital, the things that are missing, how do you balance the learning environment or the educational needs of the trainee with our very chaotic learning environment, right? And are there ways to make, so I think that the echo example was good, but in the clinical example, you know, it's such a tough balance. And so are there things that we can do to maximize that learning environment, even though it's chaos, if that makes sense?
Yes. Yeah. So I think that's the reality that we all face. Like, we would love to have a more controlled setting where we could say, okay, I have a novice learner with me today, so I'm going to schedule deliberately more simple patients for them to see because I know that they're coming and that's what they'll learn best from. But the nuts and bolts of that are really hard to implement. And also trainee schedules sometimes change. Call schedules change, things come up. So I think the more practical way of approaching it is by reviewing the clinic list at the beginning of the day, really taking that work from the colonoscopy literature to the clinic and saying, okay, how do we look at these patients? Which ones are most appropriate for you to see, and what are some learning goals around this patient? So even if the C1 is going to assess a patient with Fontan circulation, what is the most important thing that I want you to take away from that to manage their intrinsic load so that you're not learning everything about Fontan from one patient. So that's one area that we can do practically, and I think doesn't require a lot of resource or time to do. Most of us are reviewing our patients at the beginning of the clinic anyway, especially in congenital when they are so complex. From the extraneous perspective, I think defining the role of the trainee in that environment is really important. So taking it from the congenital clinic to the CCU and recognizing that the C1 who's on their first rotation, like handling outside calls or numerous pages, might make it very difficult for them to learn from the ward round. So identifying someone who's going to take those pages can be offloading in a way that's both supportive but also allows them to learn the most. And then I think the germane part, we have a lot of opportunity, both in our chaotic inpatient environments and in our clinics, to take a minute at either after the patient is done and say, okay, so what's your learning point from this case? And then discuss that, or at the end of the clinic, do a bit of a clinic review depending on time. Ideally, love to incorporate the EPA completion with that germane processing so that we're kind of doing two things at once and being more efficient, which oftentimes works, especially I'm sure your EPAs here also have that next step section, and that can be an opportunity to bring in some of those principles about comparing, contrasting, what resources should you look at to learn more about this. Those are some practical ideas.
Another question for you.
Okay.
We've seen incredible growth in volumes on all of our services. Do you have any strategies for dealing with those workloads that are kind of causing extrinsic distraction to our residents?
Yes.
Should we just be really hard about it and say, you know, limit workload, or are there ways to mitigate?
Mm-hmm. So that's a very interesting and topical question I think everyone is dealing with. So from the data perspective, UCSF in an oncology setting, Sam Braunfield studied this and looked at the number of consultations that people could handle in a daytime shift. And that data, I think, I'm not sure it's so practical because the limit was about 2 to 3 consultations. Which if we were to think about that in our reality, that's hard for me to practically apply, at least in my setting, like to say, okay, you have a limit of 3 consultations so that we can maximize your learning. But maybe the takeaway there is for the most novice learner, we do try to limit the number of patients they're seeing in a way that they can gain the most from them, and have more senior learners there that we really say, okay, now your learning goal is dealing with volume. That is a learning goal for you, because the reality is we need to graduate trainees that can handle the demands of the practice. So if during training there's all these limits applied, and then those limits expire June 30th at midnight and July 1st at 8 a.m., you need to manage all of this. You might not be so well prepared if all of the training was limited. So I think there's definitely a role early on to maybe apply some limits, but those have to be taken off as soon as that competency is shown, so that people can work on managing the volume of patients they're going to need to see, because our patients need people who can take care of them at the end of all of this. And I think there's definitely a role to repeat that data that they generated there, looking at more nuances of it, level of trainee, type of consultations. Oncology consultations are probably much different, and the decisions around them, than our cardiology context.
If there are no further questions, I'd like to thank you, Dr. Blissett, for coming to Calgary. We really enjoyed your talk. That was wonderful.